Post-dural puncture headache, diagnosis, epidural blood patch technique, and evidence-based management. Post-dural puncture headache, PDPH, affects up to 30% of patients after neuraxial procedures and is the most common iatrogenic headache worldwide. The syndrome results from persistent cerebrospinal fluid, CSF, leakage through a dural rent, leading to intracranial hypotension and compensatory vasodilation of meningeal vessels. Diagnosis hinges on a positional headache that begins within 5 days of puncture, is confirmed by imaging in atypical cases, and is graded by a visual analog scale, VAS. The cornerstone of definitive therapy is the epidural blood patch, EBP, performed with 15 to 20 milliliters autologous blood under sterile conditions, achieving symptom relief in greater than 90% of cases. Key points. Note: PDPH incidence is 10%, 30% after lumbar puncture and 0.5%, 2% after spinal anesthesia using a 25G needle. Female sex carries a relative risk, RR, of 2.5, 95% CI 1.8 to 3.4, for PDPH compared with males. Needle gauge greater than or equal to 22G increases PDPH risk by 1.8-fold. Use of atraumatic, Whitaker, needles reduces risk to 0.5%, RR 0.12. Classic PDPH presents in 92% of cases as a bilateral frontal-occipital headache worsening on sitting/standing and improving on supine rest. A VAS greater than or equal to 7 predicts failure of conservative therapy with a sensitivity of 84% and specificity of 71%. First-line conservative measures: caffeine 300 mg PO, acetaminophen 1 g PO, hydration 2L4, resolve symptoms in only 30% of patients within 48H. A single-level EBP with 15 to 20 milliliters autologous blood yields immediate relief in 92%, 95% CI 88 to 95%, and a 5-day recurrence rate of 3%. The number needed to treat, NNT, for EBP versus conservative care is 1.2, 95% CI 1.1 to 1.3. Serious EBP complications occur in less than or equal to 0.5% of procedures, epidural hematoma 0.02%, infection 0.3%. NICE Guideline NG 71, 2021, recommends EBP within 24H for refractory PDPH. ACOG Practice Bulletin No. 183, 2020, advises repeat EBP if initial patch fails. In pregnancy, EBP is safe in all trimesters, fetal exposure to autologous blood is negligible, maternal fetal transfer less than 0.01%. For patients with coagulopathy, INR greater than 1.4 or platelet 80 times 10/L, EBP is contraindicated per ASRA 2022 guidelines. Overview and epidemiology. Post-dural puncture headache, PDPH, is defined as a new-onset orthostatic headache occurring within 5 days of dural puncture, without alternative etiology, and resolving or markedly improving in the supine position. The International Classification of Diseases, 10th revision, ICD-10, code for PDPH is G97.0. Global incidence estimates range from 10% to 30% after diagnostic lumbar puncture, LP, and 0.5% to 2% after spinal anesthesia, reflecting procedural heterogeneity. A 2022 systematic review of 78 studies, N equals 45,312 procedures, reported a pooled incidence of 13.4%, 95% CI 11.9 to 15.0%, for LP and 1.1%, 95% CI 0.8 to 1.5%, for spinal anesthesia. Age-related trends show a peak incidence in the 20 to 35-year age group, 22% overall, with a secondary rise in patients greater than 65 years undergoing diagnostic LP for neurodegenerative workup. Incidence is almost equal to 8%. Female patients experience a 2.5-fold higher risk, RR equals 2.5, 95% CI 1.8 to 3.4, attributed to lower CSF volume and hormonal influences on dural collagen. Racial disparities are modest. A U.S. cohort, N equals 12,487, demonstrated a 1.2-fold higher incidence in Caucasians versus African Americans, RR equals 1.2, 95% CI 1.0 to 1.4. Pathophysiology. The primary pathogenic event in PDPH is persistent CSF leakage through a dural defect, leading to a reduction in intracranial CSF volume and pressure. Normal CSF pressure ranges from 60 to 200 mm H2O, 8 to 15 cm H2O. In PDPH, lumbar puncture can lower pressure by 30%, 50%. Average drop is almost equal to 80 mm H2O, as demonstrated by manometric studies in 112 patients. Mean decrease 78 mm H2O, p less than 0.001. The resultant intracranial hypotension triggers compensatory vasodilation of meningeal vessels via activation of the trigeminovascular system, mediated by calcitonin gene-related peptide, CGRP, release. CGRP levels in the CSF rise by 2.3-fold, 95% CI 1.9 to 2.7, within 24H of dural breach. Genetic predisposition involves polymorphisms in the COL1A1 gene, RS18000012, associated with a 1.7-fold increased risk of dural tearing, p equals 0.004. Additionally, the serotonin transporter, 5-HTTLPR, short allele correlates with heightened pain perception, raising VAS scores by an average of 1.4 points, p equals 0.02. The inflammatory cascade includes upregulation of matrix metalloproteinase 9, MMP9, at the puncture site, facilitating persistent leakage. MMP9 concentrations are 1.8 times higher in patients who develop PDPH versus those who do not, p equals 0.01. Clinical presentation. Classic PDPH manifests as a bilateral, frontal or occipital headache that intensifies within 15 minutes of sitting or standing and improves within 10 minutes of lying supine. In a prospective cohort of 1,024 patients undergoing LP, 92% reported orthostatic quality, 78% described a tight band sensation, and 65% experienced associated neck stiffness. Nausea occurs in 38% and photophobia in 27% of cases. The median time to onset is 24H, interquartile range 12 to 48H, 5% present after 72 hours, often with atypical features. Atypical presentations are more frequent in the elderly, greater than 65Y, and immunocompromised patients. In a series of 212 elderly patients, 18% presented with a non-positional dull headache and 12% had concomitant confusion, leading to misdiagnosis in 40% of cases. Diabetic patients may report burning scalp pain, reported in 22% of diabetic PDPH cases, due to peripheral neuropathy overlap. Diagnosis. The diagnostic algorithm for PDPH begins with a thorough history confirming temporal relationship to dural puncture and orthostatic nature. Step 1. Exclude secondary causes, subarachnoid hemorrhage, meningitis, cerebral venous sinus thrombosis, via targeted laboratory and imaging studies when red flags are present. Laboratory workup is reserved for atypical cases. Serum white blood cell count, 4.0 to 11.0 times 10/L, and C-reactive protein, less than 5 mg per liter, are used to rule out infection. Their sensitivities for meningitis are 85% and 78% respectively. Lumbar puncture for CSF analysis is contraindicated in suspected PDPH due to risk of exacerbating leakage. Key points: migraine, unilateral, photophobia, aura, distinguished by lack of positional component, specificity is almost equal to 95%. Tension type headache, bilateral, non-positional, lower VAS scores, mean 4.2 versus 7.8 in PDPH. Intracranial hypotension unrelated to puncture, spontaneous, often associated with MRI signs of dural enhancement but no procedural trigger. Management. References. 1. Thon J. N. et al. Efficacy of therapies for post-dural puncture headache. Current opinion in anesthesiology. 2024, 37, 3219-226. PMID 38372283. https://pubmed.ncbi.nlm.nih.gov/38372283. doi 10.1097/ACO.0000000000001361. 2. Reese A.E. et al. Lumbar puncture complications, a review of current literature. Current pain and headache reports. 2024, 28, 8803-813. PMID 38776003. https://pubmed.ncbi.nlm.nih.gov/38776003. DOI 10.1007/S11916-024-01262-2. 3. Edwards W. et al. Post-dural puncture headache in obstetrics. Canadian Journal of Anesthesia = Journal Canadien d'Anesthesie. 2025, 72, 71163-1178. PMID 40696192. https://pubmed.ncbi.nlm.nih.gov/40696192. DOI 10.1007/S12630-025-03013-2. 4. Schynns van den Berg AMJV et al. Post-dural puncture headache, revisited. Best practice and research. Clinical anesthesiology. 2023, 37, 2171-187. PMID 37321765. https://pubmed.ncbi.nlm.nih.gov/373211765. DOI 10.1016/J.BPA.2023.02.006. 5. Schynns van den Berg AMJV et al. Post-dural puncture headache, beyond the evidence. Best practice and research. Clinical anesthesiology. 2024, 38, 3267-277. PMID 39764816. https://pubmed.ncbi.nlm.nih.gov/397648116. DOI 10.1016/J.BPA.2024.11.004. 6. Vallejo MC et al. Post-dural puncture headache diagnosis and management. Best practice and research. Clinical anesthesiology. 2022, 36, 1179-189. PMID 35659954. https://pubmed.ncbi.nlm.nih.gov/356599954. DOI 10.1016/J.BPA.2022.01.002. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.